So we have seen the normal bone, then the transverse fracture, and the one pattern is oblique, which is short oblique and high oblique. Then we discussed about the spiral fracture, which are in two planes or more than two planes, or more than one plane. Then we have seen the comminuted fracture, where the fracture fragments are more than two, and there are multiple fracture pieces, and that is called the combinated. Now, the combination may be in terms of the high combination and low combination. When the fractional fragments are more than three, then it is highly combinated, and when it is less than three, that is less than four, it is low combination. Then you have got a segmental fracture. The segmental fracture in the long axis of the bone, the fracture geometry or the fracture line are passing at two different levels. So a part or a segment or a length of the bone is intact in circumference for a few inches or few centimeters, and that is called a segmental fracture. Then you have got a avulsion fracture. Avulsion is the something is avulsed from the bone, so certain ligaments and the muscles and the capsule, they are attached with the periarticular area of the bone, and usually they are getting avulsed because of the sudden forceful contraction of the muscle, maybe because of some or other action of the muscle. So that is the avulsed fracture. Now you have got an impacted fracture, where the fracture occurring and then getting impacted the same area, and you see the overlapping or a dense line of the fracture line at the fracture surface, and which indicate that the fracture is the spicules of the fracture line, they are entangled with each other at the fracture site. Then you have a torus fracture, which usually occurs in the children, where the clear-cut break in the cortex is not seen, but there is a thickening, or because of the excessive compression or the twisting, there is some amount of thickened cortex, which is not normal looking. It looks to be weakened, but it is thickened. The circumference is more than the above and the below fragments. Then you've got a green stick fracture, where the one cortex is gone or fractured or broken or breach is there, and the second cortex is still intact. And this is called green stick because this is seen usually in the plants which are still soft, and you bend the branch of that small plant, and it do bend, but at one side it is intact, that is from the tension side it is intact, and at the compression side there is a uh, you see a lot of creases, which is nothing but the fracture lines. Now we have uh, slight interruptions there in the slideshow. We are back within a few seconds, please. Okay, so grace fracture. Then you have what the type of fracture which can be classified on the basis of the intact soft tissue around the fracture, or if the soft tissue, we call it envelope around the bone, which at the place where it is fractured is not intact, that it is a open fracture, especially when it is communicating with the exterior. Then the closed fracture is nothing but the fracture is occurring, the soft tissue may be damaged to some extent, but still the skin over the fracture site is intact and is not communicating with the exterior of the environment. Then you have got types of injury which are high energy and low energy. The kinetic energy or the kinetic force, which is of high energy, like a road traffic accident where the vehicle is running, or the rider is having a acceleration of very good amount, and the velocity is there, and the patient meets an accident, and hits a car, or falls off his own because of the speeding of the mobile or motorcycle or a scooter or a four-wheeler, and gets injured of in gets injury in one of his limb or extremity, and then leads to a very high energy trauma or fracture, which are usually communicated and displaced also. Then you have got a low energy trauma, like missing a step while climbing the domestic area, climbing the stair and missing a step, and can lead to the twisting of the foot, maybe inversion or eversion. And in the case of the inversion, there is a good amount of evulsive force on the base of the fifth metatarsal and can lead to the fracture of the base of the styloid of the fifth metatarsal, and this is called the Jones fracture. All the fractures, some fractures, they are having eponymous names based on their discoverer or their inventors. And then we have got little details of the compound fracture. The compound fractures can be classified according to the amount of the wound. In the classification goes by the name of the Gustino's classification, which can be a type 1, a low energy wound when the size of the wound is less than 1 centimeter, and this usually occurring when the fractured fragment is coming from inside to outside, and usually they are not contaminated. They are usually sterile in nature. Number two is the wound when the size of the wound is more than 1 centimeter, but with a small or a moderate amount of the soft tissue damage, which is covering the fracture. Then you have got a type 3, and that is the high energy wound, where the size of the wound may be 1 centimeter or maybe more than 1 centimeter, with extensive soft tissue damage inside the wound. And this can be further divided into type A and type B. Accordingly, there can be a soft tissue, good adequate soft tissue coverage is still there in type A. In type B, there can be extensive soft tissue injury with external or internal degloving injury, which needs to be covered. And then you have got a type 3C, which is the most severe type of injury, where an open fracture is there associated with the neurovascular injury, that is, the nerve is also damaged, the tendon is damaged, the vessels are damaged, and the extremity is jeopardized because of the vascular supply. And then you have got the complications of the fractures. The complications of the fracture in general are the shock, the ARDS, the acute respiratory distress syndrome, the fat embolism, head, chest, abdomen, and the pelvic injuries. You have got a crush syndrome, then a tetanus, the gas gangrene, infection, then urinary tract infection, and we have got a chest infection, and deep vein thrombosis or pulmonary embolism. Then you've got a bad sore and depression and the PTSD, post-traumatic psychotic depression, and so on and so forth. Then you've got late complications and early complications because of the fracture. Fracture can have the distal injury in the abdomen or in the cardiothoracic area. Then you have got a vascular injury because of the injury to a large vessel like a radial artery is cut, or a femoral artery in the gunman's canal or hunter's canal is injured along with the fracture, and there can be a compartment syndrome because of the increased pressure in the compartment, and this can lead to the Volksman ischemic contracture later on if not relieved at the uh, acute emergency time. Then you have got a nerve injury, maybe because of the fracture or because of the trauma or because of the excessive traction or maybe a tractional nerve injury. Then you have got hemarthrosis. This hemarthrosis usually occurring at the places where the joint is involved in the fracture, usually in the knee joints, and sometime in the fracture neck of the or head of the radius also. You've got a good amount of hemarthrosis. Then the infection can occur early because the infection is there and the patient has got a debilitating uh, chronic problems like diabetes mellitus or a rheumatoid arthritis or some SLE or some other or a tumor or a malignancy or patient is on a immunocompromised drugs, all this can lead to the infections and and uh, and then later on the complication of the fracture can be the delayed union, the non-union, the malunion, the tendon ruptures, and the myasthenic ossificans, the osteonecrosis. Then you have got algodystrophy, then you have osteoarthritis and the joint stiffness, and then you have got the management of the injured patient. Then how to manage the patient? So the fracture can be diagnosed by means of the X-rays, but we have to treat the patient. So at the site of the X-ray, the life-saving measures should be done, and a diagnosis and treat the life-threatening injuries like head injuries, chest injuries, abdominal injuries. This to be given the priority. And sometimes the emergency orthopedic involvement is there, and that is the like your dislocation of the hip joint, which needs an emergency orthopedic management. Then you have got the emergency of the orthopedic management, that is of day one. Then you have a monitoring of the fracture, which is days to weeks. Then you have got these are all the division of the management. So emergency management, then monitoring of the fracture. Then you have got the rehabilitation and the treatment of the complications, and which goes on for months together. Then what are the life-saving measures? They are airways, then B is for breathing, and C for the circulation, and D is the disability, and the E is the exposure. All this has to be seen at the site of accident or whenever the patient is seen for the first time in the casualty or in A and E department. And these A, B, C, D, and E should be looked sincerely and with all devotion so as to save the life of the patient. Then what are the different principles of the fracture management? The principles of the fracture management are: number one is the reduction. Then you have to reduce the fracture, and once you have reduced it, you have to hold it until the union, and this is called the maintenance of the reduction. And once the union is there, then you have to rehabilitate or restore the function by movement of the joint and the patient itself. The patient should be mobilized out of the bed, and that is the rehabilitation. Then you have to treat or you have to prevent the complication of the fracture, which can be in form of the stiffness of the joint or else or the loss of sensation or something else. Then what are the different complications in cases of the compound fractures? The high risk of infection is there in cases of the compound fracture, especially when the gastro type 2 or 3 a wound or classification of the wound is there because of the openness to the environment, outside the environment, and something is penetrating the fracture site and taking the all outside infection to the inside and harboring the bacterial colony there, and can make it difficult to treat the infection once it is stuck to the bone. So the first and the very foremost formula is to treat the fracture is to give a good lavage, and you should brush the wound with a soft nylon brush and use the antiseptic solutions, and severe a copious amount of saline for a small wound, moderate sized wound, 2 to 3 centimeter. At least 10 to 12 liters of saline should be used so as to remove the infective material. Then you have got a time for the definitive management of the fracture, and you should decide where to send the patient, and it should be sent to the center where the orthopedic treatment is usually really dealt. Otherwise, you are sending a patient from the roadside to the peripheral health center where no facility is available for the orthopedic surgeon to work, though the surgeon may be available, but the setup should be there and the patient should be referred or sent to a proper place where it can be definitely managed surgically or non-surgically. And there, when it reaches the center where you have sent the patient, what they irrigate the wound the normal saline. And if that is not available because of any reason, a tape water can be used with copious amount of running flow water is used to wash the wound. And then you have to cover the wound with a sterile moist dressing so as not to cause the necrosis, dry necrosis of the soft tissue available there. Then you have to immobilize in a good way so that the patient doesn't have the pain, and is possible to transport the patient. It can be by means of the external fixator if it is available, or it can be by means of the cast or slab or some kind of splintage. Then you have got you have to see if there are any contaminants which should be removed, and you have to take the clinical pictures so as to say that this was the initial condition, and you can tally when the patient is recovering back, and that boosts the morale of the patient and of the doctor also. Then you have to use the IV antibiotics, which traditionally as cephalosporin, ceforaxime, and then gram-negative antibiotic, which may be metronidazole or gentamicin can be used. Then you have to give the tetanus prophylaxis, considering the patient is already having immunization against the tetanus. Then you have to check for the distal neurovascular status. Suppose there is a wound in the proximal part of the forearm, then you have to check for the distal pulse, that is the radial pulse, that the neurovascular status is okay or not. And then you have to go for the reduction part, and if necessary, the reduction can be closed reduction or it can be open reduction according to the need of the individual patient. Sometimes closed reduction without anesthesia or just under sedation is possible with some kind of analgesia, and then an image intensifier is available so that you don't have to go for the recheck or a check X-ray of the reduction. And all this should be available at hand so as to shorten the duration of your procedure. And cases of the most of the bone alignment is can be clinically judged with an experienced hand. Then sometimes you have to go for an open reduction because there is a some kind of interposition of the soft tissue within the fracture surfaces, and this can be done by means of the opening the fracture site and removing of the soft tissue interposition and reducing it, and then maintaining by means of either a external fixator with open fracture, or by means of a definitive fixation by means of a nail or a plate. The risk is there of infection and injury to the adjoining neurovascular structure, but in good hands, it should not happen. Then what are the need? What is the need? Why it is necessary to reduce the fracture? To reduce the fracture means to reduce the pain, because the motion at the fracture site irritates the periosteal nerve supply and causes the pain. And if you are reducing the fracture displacement, then you are preventing the malunion and you are allowing the nature to heal the fracture. And this should be maintained for a pretty long time till the union is there. And when you are reducing the fracture and you are removing the displacement and realigning the bones, then you are just minimizing the chances of the non-union, and that should be kept for a pretty long time. And in a normal long bone, it is 6 to 9 months which is required for the bone to heal. And how to maintain the reduction? So external fixator and plaster of Paris and traction through the skin traction through the skeletal traction can be done to maintain the reduction. And some internal methods are there, and they are the K-wires, the percutaneous spinning, and the plate and the nails and the screws. They all hold the fragment together in a aligned position and can maintain the reduction. Then you have got for the external fixator, you have got the plaster of Paris, which molds nicely as it sets, and during that 2, 3, 4, 5, or according to the setting time of the manufacturer, you can set the plaster in the position you need for keeping the fragments in a reduced position. But the disadvantage is the sometimes it is too tight and can cause the volumic Watchman ischemic necrosis, and then you are you may feel sorry. So it should be seen within 24 hours that any untoward swelling or excessive pain or whitening or the bluing of the nails is occurring, then it should be split and removed. And then nowadays you have got a plaster of Paris. In place of the plaster of Paris, you have got a resin cast, and it goes with the uh, layman's term, which is a fiber cast, because it's very lightweight and patient free, and to some extent it is waterproof also. And the cotton which you are using for the padding inside the cast is usually the absorbent cotton, so absorb the water and keep the skin moist, and can cause the shortening of the skin and can cause the ulcers. So that should be avoided. So nowadays a special kind of the synthetic fiber padding is available, which does not absorb the water and remains dry. If you make it in the gravity and hold the water, it drains and makes the inside of the cast dry and does not cause the soaking of the skin and can prevent such damages. Then you have got uh, surface traction like skin traction, as you are seeing in the picture. The skin can be given the traction, and through this skin, the traction goes to the fracture fragment. Especially, we are putting the traction on the distal fragment. Whichever fragment is distal, that should be given the traction. But the skin should not be too tightly compressed so as to cause the injury, and neurovascular should be checked during the surface traction, during the skin traction, so that there is no vascular uh, impedance. Then you have got skeletal traction. Skeletal traction is usually given through the tibial traction, upper tibial traction, lower tibial traction, calcaneal traction, the supracondylar femoral traction, oligurine traction. All these are the places where the skin and pin can be passed, and a good amount of weight can be given so as to cause the reduction to occur and to maintain the reduction if needed. Or sometimes is given for the wound to heal, so that the traction is maintained at the same time the wound is healing. Then you have got some other methods of reduction and maintenance of the reduction, and that is the external fixations. Then you have got certain things which can maintain the reduction by means of the internal methods, and they are the advantages are the you are opening the fracture, you are seeing the with your open eye, with your naked eyes, and you can have absolute anatomical restoration of the alignment, and then the stay of the hospital also shortens, and it also causes the functions to come back earlier. Then the indications for the such a open reductions are the fracture that needs the operative fixations, inherently unstable fracture or prone to redisplace after reduction, that is the mid-shaft of the femoral fracture because of the muscular attachments in the proximal and the distal fragments, the redisplacement can occur, and such are the indications of the internal fixation. Then you have got a pathological fracture should be has to be openly reduced and uh, and maintained in the reduction by means of the plate or a screw or a nail. Then in certain cases of the polytrauma where the more than one fracture is there, and to minimize the acute respiratory distress syndrome, you may have to go for a early internal fixation. And the patient with the necessary difficulties or the paraplegics or very elderly, the senior category patients, or the multiply wounded or multiple trauma patients, they can be given the advantage of the open reduction and internal fixation by means of the nail, plate, or screw. And but this can have a complication like the infection, non-union, and the implant failure and the refracture. Then you have got other methods of or means of maintenance of the fracture reduction, and that can be by means of the of the K wires and tension band wire, and they have got their own principle. When you join the Department of Orthopedics and go for your post graduation in the Department of the Orthopedics, you will be told about the what are different principles of the fracture by the fracture management by the tension band wiring. Then you have got certain plates and screws which can be applied directly on the bone surface, especially on the compressive side. We are putting the plate, but it is not a rule of thumb. Then you have got certain rods and nails which can be put inside the medullary canal, and that's why it is called the intermedullary nails, which can be locking nails so as to avoid the rotation of the two fragment problem in distal. Then we have got Then you have got stages of fracture which we'll be dealing in the next lecture. Okay, bye bye.